So I think the joint lecture was nice because we talked about shoulders a little. I'll go over it one more time. And we can talk about how to use this for dislocations. Who's ever used ultrasound to diagnose a dislocation? Right? It's actually fairly simple to do. And initially, I was like, well, why do I need this? I have x-rays. What's nice about it is we get a lot of patients, not a lot, but come in for pain-seeking behavior, or they're in an urgent care setting with like, I came to my shoulder, I know I dislocated it. You look, you rotate, and you can do what you want. And you can x-ray it and not worry about it. It's off your list of to-do things. So it's really nice. It's also nice for when I reduce somebody's shoulder and x-rays coming in, and if I've used procedural sedation especially, and I don't want to have them wake up, find out it's not in, so I just have them lay up, and I'll show you how to do this. I look, confirm it's in, then they can hit the x-ray and I can move on. So it makes it really easy. Let's talk about some of the basic stuff. The clinical problem for me is, right, and I'm going to base this lecture into 3 parts. The presence or absence of dislocation, right, analgesia for reduction, you can use that, and confirmation of reduction. And all 3 of the parts are separate. They can all be done with ultrasound. You can decide what you want to do, how you want to get practice. And I'd always just start with the basic stuff and move up to the more advanced stuff. And you can do this however you like. So x-rays are great, especially when the radiologist labels your lipohemarthrosis. But classically, anterior dislocations versus posterior dislocations, we see, who here sees a lot of posterior dislocations? Probably not, right? They can be difficult because you can miss them pretty easily. What's nice about ultrasound is pretty obvious, and I'll show you an example of this. And I think understanding the ultrasound, again, helps you understand the anatomical relationship and the reason why this happens, and I'll explain it to you. So, learn the normal anatomy. We talked about this very quickly. Same idea, same scapular spine, parallel to the bed, right below the scapular spine will give you that space. And again, you see that classic infraspinatus tendon, the glenoid fossa, and the humeral head, right? That classic articulation, which we like. And this is me just asking the patient to externally rotate, internally rotate. All I'm doing is getting a nice articulation. If you're articulating your humeral head with the glenoid, you are not dislocated. That's really the key, right? If I can rotate that ball in a manner close to your glenoid, you are not dislocated. And their x-rays are like, I'm sure they're dislocated. And they're rotated, I'm like, no, you're not dislocated. You just have a large fusion there. It looks like you're almost off, but you're fine. If you can rotate it, you're good. I'm going to step back. This is a video that I want to show you. So I taught a group of people how to do this at a course about 4 years ago at one of our national courses. And this physician literally worked, I think it was that night or the next night, and was working with a sex worker came in with a fever and a painful shoulder. And remember I showed you how to tap the shoulder? So she sends me this video the day later. And so use a linear probe, which I love. Let's say I have fusion. So use a different type of probe, which is okay. Whatever. Sticks a needle in. And pulled out gonococcus out of the shoulder, which I thought was pretty badass. Like, I literally taught this lady a day before. She puts a needle into it, gets gonococcus, and actually published this case series, or case report in our Annals of Emergency Medicine as a video case. I was so impressed. And she's like, sends it to me via email. Says, oh, I had this case yesterday, thanks for shooting the shoulder. Nobody else could do it. I was sitting there and I did it, and I got pus out. And I'm like, holy crap, right? Like, I thought I was just up here like pretending to be smart, like you have to learn something. So anyway, back to our dislocations. So how does a dislocation happen? And I use this slide because I think to understand the mechanism and the location of dislocations really helps you when it comes to ultrasound. For me, it's almost always, like you guys get rugby players, and that's where I got this image from, but it's classically from an outstretched hand, right? There's tons of support. You never dislocate your head up. It's too much muscle here. You have to cut your arm off. You have no muscle underneath. So the primary vector forces pushes the humeral head downward. You go down because it's outstretched hand. Once it goes down, you go, ow, that really hurts. He probably screams really loud, right? Clenches, the head goes up and sits either subglenoid or subacromial. So again, you fall down. My mom dislocated her shoulder when she was traveling. She was like reaching for the bathroom or something. She fell down. The primary vector forces pushes the head inferiorly. Once it goes inferiorly, you scream, and it comes back up. So it goes either subglenoid, right here, or subacromial. That's an anterior dislocation. And the people that get posterior dislocations, like we talk about seizures and electrical strikes, because your black muscles are so strong, you just constrict and you go posteriorly. But that's the classic person you see, is that anterior dislocation. The reduction process on either one is exactly the same. So there's no difference. So what does dislocation look like on ultrasound? And I'm going to tell you that I used to show this video, and I'm going to show this to you, and I'm like, there's a dislocation. There's the head, there's the glenoid. And that was my educational error. Because you're looking at that going, I don't know what he's looking at. I'm going to help you. So remember, the ultrasound machine wants to hurt you. It wants to confuse you. That's the goal of the ultrasound machine, right? Everything's upside down and backwards and right sides, left side. This is the direction. This is my resident's head. This is his trapezius, right? You're shooting in that direction. See the back? See the chest? This is the glenoid. This is the humeral head. So that's an anterior dislocation. Does that make sense to everybody? It's not anatomically correct, but from there you realize that if I dislocate and go anterior, my humeral head will be here. Anterior dislocation. So with that thought process, this is an anterior dislocation with no articulation. This is a normal located head and glenoid. Does that make sense to everybody? That's the difference. Let's show the next one. So this one is a posterior dislocation. Now it makes a lot of sense because now you know your orientation. And that is a normal femur. So the articulation between the glenoid and the humeral head is the key. If it's posterior or anterior, it's dislocated. And you won't be able to articulate. Does that make sense to everybody? That picture, if you have that picture in your head, you understand the entire concept, as long as you're just below the scapular spine. Everybody okay with this? Good. Because this, I had a hard time. I had to like stand above the resident, like upside down, trying to take these pictures because I wanted to show that orientation, which was very confusing to me. But once I figured that out, once that connected in my brain, this is obvious. Anterior, posterior, done. So how do you reduce it? So I'm going to tell you there's a couple ways to do it. So we like procedural sedation, so I think there's always more than one way to skin a cat, right? If there's a person who's young and comes in, hasn't eaten for a few hours, and whatever, I'm busy, the nurse has an open bed, I'll do procedural sedation. It's a very simple procedure, I pop it back in and go away. If I can't, I can try joint injections. If we're really busy, we don't have a free bed for procedural sedation, my respiratory therapist isn't there. This is kind of a cool video, I'm going to show this. So this is us blocking a patient, I'll go over how to do this. And you can see the anterior dislocation, correct? So we were just really bored, and we're nerdy, and we reduced it in real time and videoed it. Pop, right? So that's a reduction. Does everybody make sense? That's a shoulder reduction in ultrasound. Not as cool to see it in a person, but you understand the concept now, right? So that was an anterior dislocation that popped right in.
Would you mind showing? Oh, sorry.
Yeah.
Would you mind just showing it again?
Right?
Yeah.
That was me like really waiting and having my fellow pull, and it's too much work. But the idea is you understand the anatomical relationship, that's what it's meant for, right? Really, there's nothing amazing about that video. It just understands. So, ultrasound guided joint injection. We used to do this all the time, and there's some efficacy to this. My fellows take these pictures, so I'll explain the error in their ways, but it's a really good idea if you do it correctly. So, a little bit local. You can see this gentleman has a dislocated, he has a kind of flattening right there. She has the probe posteriorly parallel below the spine, and she's putting a little bit of local. And then, here's something I want you to point out, which something I didn't realize. See this little blush right here? See, she's using a long, who's injected a joint and tried to reduce it? I used to do it, it never worked for me as a resident. And the reason I realized was, like anything else, when you have a dislocation, you have a little bit of blood in there. You kind of have to get a hematoma block. You go in, you go for flashback, I use a longer needle. I don't use the normal sized ATH, I use the spiral needle, longer 3.5 inch, and you get a flashback. Then you know you're underneath the infraspinatus tendon in the joint, and then you dump in the lidocaine. See that? So then she pushes, then she, I don't know why it's not playing. Sorry. Then she pushes in.
So that's a hematoma block, essentially.
Yeah.
Right?
And that's what you generally don't do when you're doing
You can see it up here.
shoulders, is look for that hematoma.
So
And
I
that's
can now really see my knee.
Right?
Oh, so that's,
So who recognizes the fatal flaw in this video?
No aseptic technique.
Yeah, she should wear a glove, right? I mean, it's like not even like not in India, right? She's just like this is not in Bangalore, like throwing. I was like, oh my God, put a glove on your hand before you do a block. So other than the non-glove part, she was okay. You'll see here, that same video, there's that dislocation, there's the blood. See that right there? So she gets, and here's the infraspinatus tendon right over here. Here she gets right at the infraspinatus tendon, just to pop through that. Aspirate. See, now she's going to aspirate a little blood, and she knows she's in. And then inject the anesthetic. That gives that nice hematoma lock. And then you can reduce it. What I used to do as a resident was get a 25 gauge needle or a 22 gauge, 21 gauge needle, go in, hub it, inject, and then get no pain relief. And I'd be like, it doesn't work. I was using the wrong needle. And I wasn't getting into the joint underneath the infraspinatus tendon. That's one option. The other one is something we've done a bunch of these, we haven't published this series yet. We call it a low volume interscalene lock. And this is nice because it allows you to do just the C5, C6 nerve root and get some anesthetic in that region and then reduce it, and I'll show you. So again, I talked about this yesterday. When you find your artery, your carotid, and your internal jugular, here's your interscalene muscle, here's your middle scalene. The C5, 6C root, right? The higher roots innervate higher up. Your shoulders kind of C5, C6. Dumping in a small volume here is nice because you just get nice shoulder anesthesia. Your phrenic nerve lays right here. By dumping a large volume, a lot of it spills over. It'll give you a little phrenic nerve paralysis, which I really don't care about. But it's nice to just get good anesthesia to the shoulder and do it just for yourself. So here is that prevertebral fascia, and the goal is to pop underneath it and dump in some anesthetic. Again, same idea, you roll the patient over. I put a shoulder roll underneath here to get a nice view. Machines contralateral. Here's your brachial plexus. Here's your anterior scalene. Here's your middle scalene. This is that fascial plane that I want to get under. Once I get fluid underneath this fascial plane, I'll get some of the fluid to drip around C5, C6 and get good block. Again, same idea, and I'll show you some video of this. You want to start with the IJ carotid, slide over your anterior scalene, your middle scalene, this is your brachial plexus. The videos will be much nicer. And here, same patient, there's that needle coming in. Does everybody see the needle up here? What I want my resident to do is kind of get right underneath that fascial plane and inject. And by doing so, again, this is probably more volume than I need, fluid will kind of cover this little area. That's all I really need. With that, I can get a nice reduction. I don't need C5, I don't need C7, I don't need C8, I don't need T1. I just need C5, C6. It's a nice little trick if you want very specific analgesia to the shoulder region.
Aaron, what sort of volume are you talking there?
We put about 5 to 7 cc's. Yeah.
Would it work for your proximal people?
So, turn this. Sorry, I didn't realize the volume's going to come on this. So I classically, for him, you could theoretically, but I like to put a large volume because it hurts for such a long time. So I like to give a bigger dose. If I'm sending somebody home with for a proximal humerus fracture, I'll put 10 cc's of bupivacaine in the shoulder, or bupivacaine, whatever you like, and really give good anesthesia. So again, this is my resident popping it in. And what's nice about this in the training program, you can get one of your residents through the procedure, and then you can walk your med student through a nice simple reduction while the patient's wide awake, and you're just like, you're teaching them how to kind of slowly pop the shoulder in. And it already pops in, he's comfortable, the patient's happy, and you can move on. Which is nice is that it's a nice way to teach both parties how to do this. And you already know reduction confirmation. Once you've done the reduction, you can easily check. This one is in or out. You can see a needle going in, so it's probably out, right? There's the humeral head right there. This is the glenoid. Is it that same one, in or out? Yeah, right. That's really what you're doing. And these are great views. I kind of purposely don't use perfect views because you want my providers to be comfortable saying, yeah, it's clearly in. There's rotational, you're rotating it, and they rotate right at the end. You'll see at the end they'll rotate it. Right there. That means it's in. And once it's in, you're done. Get the x-ray, whatever you want to do, however you play your game in your hospital. So I think ultrasound is nice for the diagnosis if you need it. It's also really nice for analgesia if you like. And it helps you in the confirmation of reduction. So however you want to play this game, this is really a fun thing. Start with 1, work 2, pick 3, kind of do what you like. Questions?
The intra-articular block, you took a different approach to that aspiration. Is there a...
So let's say the patient was right here, I had the machine in front of me.
Yeah.
Let's say it was on this side. On this side, I'd hold the probe like this, below it, I just come in like this.
Rather than over the probe, because on that aspiration...
Yes, aspiration will be, it'd be out of plane.
Yeah.
This would be in plane. Yeah.